happens. This is a case of an ACL injury where there was an isolated ACL complete tear. ACL injuries occur with a pivot shift event. They can be associated with isolated twisting injury with non-contact or with contact. In the scenario of the pivot shift, the thigh bone rotates one direction and the leg bone rotates in a different direction. ACL injuries present on a spectrum dependent upon the amount of energy involved in the injury event. That energy can be at different levels and represents and presents different levels of injury. Isolated ACLs on one side of the spectrum and ACLs with 2 meniscus tears and cartilage injury on the other end of the spectrum. And in between, individual injuries of all types, including ACL injuries with 1 meniscus tear, ACL injuries with 2 meniscus tears, and all are individual in terms of their injury pattern, but there are some trends that we see. We always start with the story of the injury, and it typically involves a twisting event, a pop, and patients often report that they fall to the ground. They are unable to continue to play that day, and the knee swells. After the knee swells and normal life is resumed, patients often report feelings that the knee gives out on them. Making a diagnosis starts with the history, and 80% of that diagnosis is the history. This patient is a 22-year-old college basketball player. Physical exam is 15%. There's a grade 2B Lockman test and a grade 1 pivot shift. X-rays help us think about risk factors for ACL injury. This patient had a neutral mechanical axis and a posterior tibial slope of 10 degrees. And MRIs fill in the details and confirm the diagnosis. This MRI revealed a bone bruise pattern, an isolated ACL tear, and intact meniscus tissues. When we first get into the joint, we look first at the patellofemoral joint and then down into the intercondylar notch. 10% of the native ACL was in continuity in this case, 50% had flipped forward and was incompetent, and the remaining 40% was detached from the femoral origin. We first remove the femoral stump and the tibial stump of the native ACL. We then begin what's called a notchplasty, and that notchplasty affords for more space for our ACL reconstruction so that we'll have a less risk for a re-tear or re-injury event. It also recreates some nice bleeding bone that allows for maturation and to improve that process. We then evaluate the meniscus tissues, first the lateral meniscus, using a probe to confirm the root is intact. Also, many times there can be a longitudinal tear in the posterior aspect of the lateral meniscus right at this location that you see me probing here. In this patient, there was a scuff, but it was intact. And then that's a nice view of the ligament of Risberg, which is a normal structure in the lateral meniscus. We then evaluate the medial meniscus, similar probing to ensure its competency. Many times with ACL injuries, there's a longitudinal tear in this position of the meniscus. We also drive posteriorly to ensure that there is no ramp lesion. For the ACL reconstruction, we create a socket in the femur and then a tibial tunnel, or a tunnel across the tibia. We then shuttle the graft through the tibia, and the patellar plug of our graft goes into the femoral socket, and then we check our tension and we confirm that we have full extension without graft impingement. So we first start by critiquing and improving and perfecting our tension, and then making sure that we have no impingement of the graft at the top of the intercondylar notch. Our rehabilitation and return to sport is typically 9 months, and this is based upon studies looking at re-injury risk and how it decreases at each month until the 9-month time point. Phase 1 begins with regaining full motion and normal life function, toe touch weight bearing for the first week, typically because we're utilizing a block, and then a 1-week crutch wean as we wean and allow the quad to return its function. Rehabilitating full strength and neuromuscular function is weeks 7 through the 7.5 month time point, and phase 3 is agility and sport-specific function at 7.5 months through 9 months. Phase 4 is the return to sport, which typically is at 9 months, and that may seem like a long time, but there is some evidence that guides this process. See our blog on when is an athlete ready for returning to contact sports after ACL surgery. And one thing I many times tell athletes is that there is no I in team, but there surely is an I in injury. So take the time that it takes to regain your full muscle strength, your full proprioception, and allow for graft maturation.